Hello, and welcome back to another episode of Chronicles with Expert. Today, we'll be diving into one of the toughest challenges while managing ocular surface patients, glaucoma in KPro eyes. And who better than Dr. Sripriya, a very senior glaucoma consultant at Sankara Nethralaya, Chennai. What makes her so inspiring is not just the 2 decades of experience in managing these complicated patients, but it's the surgeon that she is, dynamic, precise, and fearless. A very, very warm welcome to you, Dr. Sripriya. It's truly an honor to have you with us on board today. And to make this conversation flowing, I have with me my two wonderful colleagues, Dr. Varsha and Mukundan from Ocular Surface Clinic at Sankara Nethralaya, Chennai. Welcome to you guys as well. Let's get started.
Hi, thank you, Dr. Shweta, for such a warm intro. And I also thank the surface consultants, Dr. Mukundan and Dr. Varsha, for giving me this opportunity. One of the things that I always think about glaucoma management in ocular surface disorders is the glaucoma decision is never by the glaucoma consultant per se. It is also dependent on the planning by the primary caregiver, who is the ocular surface consultant. So it is always in tandem, and the decision is totally dependent on what they have in mind. So with that, I think we have to walk through how glaucoma is going to go.
Ma'am, a very warm welcome to you once again, ma'am. So
Thank you.
to give our audience a roadmap, ma'am, we have broadly divided our questions into 3 parts. Like first, how do we diagnose glaucoma in the KPro eyes? Second, how do we approach the management, both medically and surgically? And finally, how these patients are cared for post-operatively after the keratoprosthesis. So let's start it, ma'am. To begin with, ma'am, we all know that glaucoma is one of the leading causes of blindness in the general population also. But when it comes to the KPro eyes, what do you feel that how common is glaucoma in these eyes? And like roughly, what is the percentage that you would say the KPro eyes are affected, ma'am?
The glaucoma in KPro eyes is dependent on the etiology also, and the risk of glaucoma even pre-keratoprosthesis varies between 20 to 60% depending on the cause for the original insult, and it rises by another 30 to 36% in eyes who have undergone a Boston type of keratoprosthesis, and about 10% in eyes that undergo the modified osteoodontokeratoprosthesis, MOOKP.
So, ma'am, to follow up on that, are there any specific history or predisposing factors that make these patients more prone for developing glaucoma?
Yeah, that's a very important question, Dr. Mukundan, because the most important cause for the glaucoma is the etiology. So, depending on what was the original insult, the glaucoma incidence varies. Chemical injuries, especially alkali burns, are definitely the greatest cause for glaucoma. Anaerobic eyes have a slightly lesser incidence of glaucoma compared to chemical injuries, and those that produce surface inflammations like your SJS and OCPs are having the least amount of glaucoma. Age is also an important factor, because if they are very old, then probably there may be a pre-existing primary glaucoma hidden within. Other surface related issues also need to be taken into consideration, because if the patient is having a corneal melt or a perforation, or he has had a tectonic PK done, you know that the chamber is flat and the angles are compromised. So there is a higher chance of having a pre-existing glaucoma. One other important factor is the time between the original insult and the patient reporting to the ophthalmologist, because the longer the duration, the higher the chance that the glaucoma was missed in the battle of the acute management of the disease.
Thank you so much, ma'am. Diagnosing glaucoma in these patients itself is a challenge, I believe. Evaluation of intraocular pressure in itself is often difficult, and that makes the diagnosis tricky. So can you share with us some tips, tricks, pearls, that how do you actually diagnose in these patients glaucoma preoperatively, and what are the kinds of tests that you would like to do before planning on a keratoprosthesis?
Before we decide on how we diagnose glaucoma, one of the important problems that we have to realize is many times the glaucoma gets missed because the ocular surface is so inflamed, there is chemical injury, there's complete epithelial defect, or symblepharon corneal melt. So the entire concentration is on reconstructing the surface and in preserving the anatomical eye. So there is always a possibility that the glaucoma gets missed initially because there is no evaluation done. Even if you think of evaluation, an inflamed surface is not going to be very conducive even for a digital estimation of the intraocular pressure. Apart from this, in the chronic phase, the applanation tension doesn't work. Tonopen is variable, can give you some idea if there is some small surface of cornea that is untouched. There are reports of intraocular pressure measurement over the sclera or on the surface with the shears, and the diatom tonometer, which is a transpalpebral measurement of intraocular pressure, has also been reported in literature. But all these these things are very, very unpredictable in the accuracy. The finger tension probably is the most important clinical clue that the treating surgeon will have. Apart from it, the surface is inflamed, so the patient's ability to tolerate the drug becomes very less, and the penetration of the drug is also very unpredictable because of the symblepharon or the fleshy vascularization that will be covering the ocular surface. Normally, glaucoma assessment is based on intraocular pressure, visual fields, disc assessment, and the angle, none of which can be done in these eyes. All put together, your assessment of the glaucoma itself is a big question mark. So the preoperative assessment of intraocular pressure will predominantly be based on digital tension. Other things like a proper anterior segment evaluation will give us an idea whether there is a well-formed chamber, because incidences like SJS or OCP, you expect the anterior chamber to be well-formed. Type of chemical injury, like a Roper Hall 3 or 4, you know that there is going to be much more angle injury and so higher chance of glaucoma occurring. Reverse RAPD in case one eye is involved, or in situations where you have no clue, then a VEP may also be needed in assessing the extent of the optic nerve injury, which may in turn give us an idea of the intraocular pressure. UBM is another important tool. It tells us whether the chamber is formed and also gives us an idea of the angle of the eye, whether extensive peripheral anterior synechiae, which are one of the reasons for the glaucoma, and whether the eye is phakic or not. But in many of these eyes, the surface is so irregular or there's ankyloblepharon that a UBM may not be possible. ASOCT, once a keratoprosthesis is done, or if it is a post-PK, multiple failed hereditary keratoplasties or anaerotic eyes, or SJS, ASOCT may give us some indication of the anterior segment. With all these put together, the surgeon will have to take a decision about the glaucoma management. Intraocular pressure alone will be of no use.
So thank you, ma'am. That was very informative. So as you said, it's about putting together all these pieces preoperatively. But does it the same hold true for diagnosing glaucoma post KPro also? Once you have a view of the posterior pole, and that point, any other history you would like to look for, or any specific test you rely on this post-operative follow-up? And do these tests vary between different types of KPro?
Okay, that's a very valuable question, Dr. Mukundan, and it's quite an elaborate answer that I'm going to be stuck with. Post keratoprosthesis, your glaucoma management in a sense gets better because you can at least have a look at the disc. Whenever the retinal surgeon enters the eye, definitely we will take a look at the optic nerve and make a record of it, because that is going to help you in your post-operative decision making. Once you have an idea of the magnitude of the glaucoma, you also have an idea of the amount of intraocular pressure reduction that you would like to aim for. The aggression for the glaucoma management is going to be much more when it is a type 2, because we are going to close the lid on top of the keratoprosthesis. So if any management needs to be done, it needs to be done prior to the KPro, or along with the KPro, definitely a glaucoma drainage device is placed. Again, digital tension helps us. Digital palpation becomes a problem because you need to note down in your records where you have placed the valve, because on one side you have the metal of the keratoprosthesis, on the other side you have the plate of the GDD. So between these two, you will have to do your digital tension, because measuring on top of these surfaces is going to give you a falsely high value. If you have an OOKP, then the entire the bone outline, you have to cross that before your digital palpation can be done. There are reports of sheared stonometry on the temporal aspect of the sclera beyond the keratoprosthesis for intraocular pressure measurement as a tool, which is fairly reliable. You can also do Humphrey visual fields. The keratoprosthesis gives us almost a 70-degree field. So definitely a 24-2 and a 10-2 is going to be extremely useful in monitoring the patient's OCT of the RNFL and the GCCs will also definitely be possible. Recording of the disc, either with a photograph as a disc photograph alone, or even in an optos if you have it, will also help us assess the disc, because subtle progression will be noted by slight change in the contour of the blood vessels. Even a diagram of the disc will help us follow up these patients. Because we do not have the intraocular pressure as a measure, these things have to be followed up every 3 or 4 months. And based on that, we'll have to decide whether the glaucoma is under control or not.
Thank you so much, ma'am. So if I may summarize, ma'am, like diagnosing glaucoma glaucoma in these eyes, both before and after keratoprosthesis, is often challenging, and it's just never about intraocular pressure alone, but rather it's a multimodal approach, correct? Looking at the etiology, risk factors, digital tension would be the go-to for assessing the intraocular pressure. Preoperatively, UBM might help, and postoperatively, it's mainly relying more on the structure and the functional optic nerve assessment with serial documentation.
Exactly.
So moving on from the diagnosis to the management, ma'am, suppose we have a scenario that where a patient already has a raised intraocular pressure, even before we plan the keratoprosthesis. So in such a scenario, ma'am, how do you decide on the management? I want to ask two specific questions, like how do you decide between the medical and the surgical therapy first? And second, if a surgery is needed, ma'am, which is the surgical option that you would prefer?
That's an excellent question, Dr. Varsha. The management between medical and surgical. First, let us take that portion. That depends totally on the state of the eye at which you are going to see the patient first. If he comes in the very acute phase, then topical medications may not be possible at all, in which case you will have to keep them only on oral medication. Acetazolamide is the go-to drug. In that, I would also like to mention that even if the patient is sulfur allergic, they may be able to tolerate acetazolamide because the sulfur moiety is not in the same location as in the sulfonamides which originally produce the SJS for the patient. Once the surface is not acutely inflamed, topical medications will be the first line of management, and in that also you have to prefer a preservative free drug. If the patient's surface is very irregular, because the drug absorption will also be less, or if the patient needs more than one or max two medication, we will have to move to a cyclodestructive procedure to control the glaucoma. So cyclodestructive procedure, again, you need to reassess the surface, and if the surface is too fleshy or there is ankyloblepharon, in coordination with the corneal surgeon, you'll have to decide when they are going to take up the patient to open up the eye for probably a fornis reconstruction or something, and at that stage, on the bas sclera, you will have to do the diode cyclophotocoagulation. If the surface is all right and there are some areas where you think you will be able to reach the scleral bed, then you can apply the diode directly on the globe. Avoid the 3 and 9 o'clock meridian just like in any other diode CPC, and also keep an eye on where the stem cells, if any, are still intact, because we would like to again avoid those areas so that the risk of post-procedure epithelial breakdown automatically comes down. If the surface is all right, then it again depends on the surgical plan of the ophthalmologist. If they are planning a keratoprosthesis right away, you can decide if the glaucoma is well under control with just one or two medications and it is going to be a keratoprosthesis type 1, then you can definitely ask them to go ahead with it, because post-operatively, one, you can always add on acetazolamide to control the glaucoma. Second, we will be able to assess the disc and then take a call whether the glaucoma is well under control or we need to move to any surgical intervention. Third, we can always go in and do a glaucoma drainage device or add on any endoscopic cyclophotocoagulation or a diode CPC later on in the post-operative period, because it is going to be a eye that is going to have the lids open. Whereas if they are thinking of a keratoprosthesis type 2, or if the Boston type 1, if they are planning, is a patient who is having a high IOP digitally in spite of being on two medications, then definitely we need to move to a glaucoma drainage device along with or prior to the keratoprosthesis. So how do you decide whether it is going to be along with the keratoprosthesis or prior to it? It totally depends on the surface of the eye. If you think that the conjunctival breakdown will not occur, because mainly you need to look not close to the limbus, but near the fornix. So if the fornix is healthy and you will be able to do a GDD, then a glaucoma drainage device will be the first step, control the glaucoma, and then the surgeon can go ahead with the keratoprosthesis. If the surface doesn't look too good, then you may have to combine both, in which case the retinal surgeon will do a pars plana vitrectomy and you will be placing the tube in the pars plana region so that the risk of post-operative tube exposure automatically comes down. If they are planning a type 2, immaterial of what the disc is, we will be combining it with a GDD device in the pars plana, because any intervention will need an opening of the entire lid apparatus and then going in. So it is always combined with the Boston type 2. If it is MOOKP, if there is definitely glaucoma, again, before the OOKP, we are going to do the GDD. If they have moved to stage 1A, then we can do it either at the end of 1A or after 1B plus C, because once the mucous membrane is placed also, then the pressure can go up. in which case, again, with the corneal surgeon, we will have to plan the placement of the glaucoma drainage device. In most of these devices, I would prefer a valved device over a non-valved device, because in a non-valved device, especially in type 2 KPro as well as in OOKP, we will not be able to do the post-operative modulation of the rib cord that we will be able to do in a normal patient. We will be able to do non-valved devices in Boston type 1, but that depends on severity of the glaucoma to start with and whether the patient will be able to stay back and come for close follow-up. If the severity is very bad, or if the patient's follow-up is not going to be that easy because he is from a far-off place, again, the decision will be to shift to a valved device over a non-valved glaucoma drainage device. And when you are placing the valve, the quadrant that you place in is also never predetermined. You will be taking your decision on table, because when they open the vascularized tissues or when they're opening the mucosa, you will be able to assess the sclera. You may be able to see some area of ectasia, thinning, in which case the valve has to be placed in a quadrant where the fornix and the sclera are going to be healthy. So this is how you decide when you place it and where you place it.
So thank you so much, ma'am. You have made it crystal clear with your insightful explanation. But to summarize, the aggressive preoperative control of intraocular pressure is crucial, and understanding the type of KPRO plan, whether type 1 Boston KPRO or type 2 Boston KPRO or OOKP, is a key factor in guiding management. For type 1 KPRO, further surgical intervention like AGV are relatively easier, and topical anti-glaucoma medication can be still used post-operatively. So surgery may sometimes be delayed. In contrast, whereas in type 2 KPRO or OOKP, medical therapy has a limited role, and if IOP is high, surgical intervention is usually necessary. In Boston type 2 KPRO, we typically perform an AGV proactively as a post-operative pressure rise is more common. So, ma'am, in this complex scenarios, where does the role of the conventional trabeculectomy surgeries or endo-CPC place?
Conventional trabeculectomy hardly has any role in these eyes, but suppose the patient also has a mature cataract. While the surface is settling down, it has become intumescent and you're planning a cataract surgery, temporary to tide over the pressure because the surface is so inflamed, patient is not able to tolerate the anti-glaucoma drug. You can do a cataract extraction with a trabeculectomy. It may maximum work for a month, but that is the time period when the patient is going to be off medication. So that's the only indication. And coming to endoscopic CPC, that will be combined with the retinal surgeon. We can use it as a diagnostic modality also, because there are conditions where even the VP will look extinguished and the patient may be just PL. Sometimes he will say yes, sometimes no. You are not very sure what is the next line of intervention, and that is the only seeing eye, only potential eye of the patient. Then you can do an endoscopic evaluation of the disc. If you think that the disc still looks viable, then you can be much more aggressive with your surgical management and going up to a keratoprosthesis. But if you find that the disc is completely pale, sometimes intensity of the primary insult was so severe that the patient is having completely sclerosed vessels. And then in that case, it is not going to be keratoprosthesis. Endoscopic CPC can be used to do cycloablation. There is not enough literature or long-term follow-up on that, but definitely it has a role to play. If you are combining with the pars plana vitrectomy, then an endoscopic CPC can be done as a first option. And if it is not able to control the glaucoma, then the GDD can be added on top. The greatest advantage is the lesser risk of infection created by the absence of one more device on the surface.
Thank you so much, ma'am. I gather that valve devices are the go-to options for these kind of eyes, ma'am. So what are the complications that one can face if performing AGVs in these type of patients, ma'am?
Like we have discussed in detail about the preoperative judgment, that is so important in the postoperative outcome. Intraoperatively, like I mentioned earlier, the scleral thinning or something is going to determine where you're going to place the valve. During the surgery, sometimes, even though you prefer supratemporal quadrant, the fornix will be much better, much more healthier with lesser adhesions in the inferotemporal or inferonasal quadrant, in which case you may have to place the valve in that area. In OOKPs, especially if you're doing it after stage 2, area where the bone is just up to the limbus is going to determine the place where you're going to insert the tube, but that may not correlate to the place where you have space to put the valve. So do not trim tube length prematurely. Decide which area there is space enough for the plate to be fixed, and then between the corneal surgeon and you will take a call as to where the bone extent is the least, and that will be the area where you're going to insert the tube into the anterior segment. So that the plate may be in the supratemporal quadrant, and the tube may be in the supranasal quadrant. And these are all very important things to be also mentioned in your operative notes, because in your future surgical dissection, you shouldn't end up chopping off the tube because you don't even anticipate it to be there. So it is always freelancing. You have to think on your feet when you are doing surgeries for these eyes. For the Boston type 1 and 2, and as far as the placement of the tube is concerned, if you have an idea of the limbus, it is going to be 8 millimeters behind the limbus. But suppose you are not able to assess the limbus at all, then it will be 13 millimeters from the center of your cylinder, because it is going to be 5 millimeters from the center of the cornea to the limbus, and then from the limbus it is going to be 8. So 8 plus 5 is 13, and that is where you're going to anchor the plate. You can also apply mitomycin C on the undersurface of the conjunctiva when you're doing the valve for Boston type 2s and OOKPs, because the risk of post-operative encapsulation and hypertensive phase are a major problem in these eyes. So post-operatively, keeping the patients on oral acetazolamide at a lower dose is the equivalent of giving topical anti-glaucoma medications, because that is a proven way of controlling the hypertensive phase post glaucoma drainage devices, especially the valved ones. So we keep the patients on Diamox for 2-3 months till the hypertensive phase of the valve is over. Post-operatively, you also take a look at the height of the bleb over the plate. You may be able to even feel it over the closed skin, because that will tell us whether the valve is functioning or it is not working at all, or the patient is having a very high elevated bleb over the plate, which means the patient is having a hypertensive phase.
So thank you so much, ma'am. We had an extensive discussion on the intraoperative challenges. Now we'll move on to the post-op care. From a glaucoma perspective, how frequent should be the follow-up in these patients post-surgery?
Yes, this is one of the toughest questions to answer, I guess. Postoperative follow-up is going to be determined by the health of the disc at the time of the keratoprosthesis and the original cause for the glaucoma and how you have managed the glaucoma. If the patient is just on 1 or 2 medications and the disc is reasonably healthy, you know that there is some amount of angle still functioning for the patient. So you may be able to call him after every 3 or 4 months. But if the patient is having very advanced glaucoma, or if the patient already needed multiple diode prior to the actual keratoprosthesis, and you ended up putting a glaucoma drainage device along with the procedure if it's a type 1, then you know that it is a very advanced form of glaucoma. So any IOP spike is going to destroy whatever visual recovery the patient has achieved. So in that case, your follow-up has to be very close, even 1 to 2 months, because the glaucoma progression in these eyes is almost 4 times faster. And the follow-up will be still based on disc photograph, your intraoperative documentation of the disc, your visual fields, and your OCT. Many times, the patient may not be able to do a visual fields because of acid destruction of even his fingers and all that, or they may be not able to place their chin. So in which case, it may be just the disc photograph that helps them follow up. If they develop a retroprosthetic membrane or they develop some other retinal disease also, parameters that you get out of the OCT will change. So when that changes, you do not know whether it is a glaucoma progression or whether it is the retinal disease that is causing this kind of a change. So this photograph, I would put it as the top in the list.
So, ma'am, to add on to that, how do you manage glaucoma post-operatively in these patients? Like, how do you assess the IOP post keratoprosthesis, and does the approach of managing glaucoma differ depending on the type of the keratoprosthesis? Like, is it different for type 1 Boston KPro, type 2 Boston KPro, or an OOKP?
Let's take it in the reverse direction. In OOKP, because the incidence of glaucoma is much lesser, because the optical cylinder is also much smaller, and the indication for doing the OOKP many times is the SJS and the keratinized surfaces, where the pre-OOKP glaucomas are much lesser. Your follow-up can be a little more relaxed. Whereas if it is a type 2 Boston or a type 1 where the glaucoma is more advanced, then the follow-up is going to be closer, literally every 2 months. So I would rather put it as the intensity of the glaucoma or the magnitude of the glaucoma is going to determine the closeness of the follow-up, rather than whether it is a type 1, type 2 or a OOKP. Also, it's going to be determined by how many medications we are going to send the patient home on. If with just one medication or just Diamox, half a tablet thrice a day, he's under control, then your follow-up can be a little more relaxed. Whereas if he is on one tablet 4 times, which is the maximum dose acetazolamide that a patient can tolerate, then you know that his follow-up has to be very close, because anytime he is going to lose whatever vision he has.
And ma'am, any specific tests that you would like to do at all these follow-ups?
So every follow-up we will have to do the OCT or the fields or both, and once in maybe 6 months do the disc photography, because serial disc photographs is a very, very important tool in monitoring the progression of glaucoma. If the patient is able to do a reliable visual fields, that's a very good tool. Problem with the OCT is that sometimes the quality of image is not good because the signal strength may be a little low, and also if the patient develops epiretinal membrane or a CME, then that is going to affect the GCC and the RNFL values, which you will be getting confused with, thinking that it is a glaucomatous change. A combination of all three will be the ideal scenario. So maybe every 6 months disc photograph, and every 3 months either a OCT or a fields. A reliable fields, then advanced glaucomas I would still prefer to follow with visual fields over an OCT.
So thank you so much, ma'am, for sharing your post-op pulse. Just to summarize for our viewers, this post-op glaucoma monitoring in these patients are almost similar to the other patients, but with an important caveat. They are at much higher risk of progression and follow-ups needs to be closer. And intraocular pressure measurements also can be unreliable. So careful measurement of the optic nerve structure and functional status is very, very crucial. So to end on a final note, ma'am, what your take-home message for glaucoma specialists and practitioners who are involved in managing these KPro patients?
The first point will be to keep an eye on the intraocular pressure while the acute phase of the injury is being managed, because many times the glaucoma starts there and that gets missed in the intensity of the ocular insult that the surface consultant is facing. Once the glaucoma is diagnosed, always tip towards diode CPC. Be much more aggressive with that than medication, because medication is not going to help effectively enough for the reasons that we discussed earlier. You can be very aggressive with diode cyclophotocoagulation by applying it on the pars sclera whenever they are opening the eye. Move to glaucoma drainage devices whenever the keratoprosthesis is planned, depending on the extent of the optic nerve injury. For a Boston type 2, it is always combined with the GDD, and a pars plana route is preferred to a anterior segment route for the placement of the tube. Follow-up is going to be based on disc assessment with disc photography, serial, OCTs, and Humphrey visual fields. The best method to monitor the intraocular pressure will be digital tension. Other tests are tried, but reliability is still very variable. And the greatest tool for glaucoma management is an extremely alert ophthalmologist. And thank you so much. I had a wonderful time going through the whole story with each one of you.
Thank you so much, ma'am, for your valuable insights and pearls. And I feel that it's been a privilege to learn from your vast experience. The viewers will be helped immensely from this discussion. For any doubts or any queries, you can always mail to us, or you can leave a comment in the chat box, and we will be happy to get back to you. Until next time, stay tuned, and we will be back with another insightful and exciting episode on Chronicles with the Experts.
Thank you so much.
Thank you, Dr.
It was lovely having you.
Thank you, ma'am. Thank you.
Thank you so much.